lecture, and then y'all are gonna rock that exam on the 7th of November, okay? All right, so you know when I do these reviews, you know that each one of these is probably connected to a question on the test, right? So please, 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 please pay attention. Of course, my clicker don't wanna work. Okay. All right, so urinalysis 1, that was our first lecture. We talked about the types of urine and specimen collection. So the ones that I wanted to emphasize for you all was, do you remember what the preferred, what is the preferred specimen that we like in the lab that I would like to know? That midstream clean catch, right? What is the sample that provides as a quantitative measure of chemical substances? 24-hour urine, correct. Abnormal colors. Although abnormal colors is not really something you'll necessarily see on a UA, but for the sake of the test, the one that's highlighted you'll see again, and what is that? Okay, and what is that, what levels are we looking for, or what's causing that blue color? Tryptophan, correct. All right, significance of positive urine glucose results. So just know the difference between that hyperglycemic associated versus renal associated, okay? So hyperglycemic associated, what's that top condition? Diabetes. And the renal associated, that top one there? Fanconi syndrome, correct. All right, so abnormal specific gravity results. So a low specific gravity, less than 1.005, is also called a what? Hypotensiuria. Diabetes insipidus, that's what it's associated with. If you have a high specific gravity, we're looking at some causes of what? It's concentrated urine, and what would you see in your patients? They're probably what? Dehydrated. They probably got some type of kidney disorder, something going on, some kidney injury, or some renal tubular acidosis. Okay, so this is a clinical significance of osmolality. Remember, I told you to know this slide. So if it's normal, you have a 1 to 1 to 3.1, that ratio is normal. So that's a healthy hydration and healthy kidney function. If it's high, where you have the urine concentration is higher than the blood and plasma, you're thinking dehydration, excessive sweating, vomiting, and diarrhea. And then for low, the urine concentration, if it's lower than the blood plasma, you're thinking diabetes insipidus. But there's two different kinds, right? Neurogenic and nephrogenic. Y'all remember the difference between the two? It's on the next slide, right? So if you have to distinguish between the two, you're going to provide, what's that test up there that starts with the M? Miller-Moses test, right? And so for that procedure, you provide your patient with that controlled fluid intake, you inject them with the ADH injection, right? So if that ratio increases, the urine to serum ratio increases, you're thinking neurogenic, and that is interpreted as inadequate ADH production. If the ratio stays low, we know that's nephrogenic, and that is interpreted as the kidneys are not responding, right? Something going on with the kidneys. Okay, so brain versus kidney. All right, so benign transient causes of protein urine. What's that highlighted one? Yeah, that's how you need to count that. Okay. Laboratory findings. Remember I said just memorize this slide. You will be tested on hepatic. So really, hepatic is like really, really highlight that. But just know this whole slide, okay? So when we talk about different types of jaundice, hepatic is you deal with chronic viral hepatitis or cirrhosis, right? So you have that increased blood bilirubin, that unconjugated, decreased conjugated bilirubin, negative urine bilirubin, decreased urobilinogen, and tan-colored feces. So what was nitrites again? Bacteria, right? Okay. And so the ones on the right, those are those common ones. E. coli is your number one, top one, right? And then off to the left, where can those false negatives come from? Y'all remember?
Staph.
What? if you let that urine sit around too long, right, that bacteria is gonna grow in that urine, and call false negatives, all right? For UTIs, what are we looking for? And I know it's not here, but UTIs, what do you see in UTIs? White blood cells, nitrates, bacteria, sometimes red blood cells, sometimes mucus, okay? And what are a list of non-bacterial infections? Trichomonas, yeast, chlamydia, mycoplasma, and different viruses, okay? Then we talked about urinalysis 2. Clinical significance of RBCs reported as what? Hematuria. Yeah. And what kidney stones are associated with what type of stone there that's highlighted? Uveitis. All right. And you can also see this in UTIs. All right, squamous epithelial cells. Remember, these are normal flora. But if we see our laboratorians in the lab, if we see greater than 10 squamous epithelial cells, what are we calling it? What?
Dirty catch.
It's not a clean catch, right? Okay. And so then that comes back to you. Please educate your patients to provide a clean catch. And the reason why we have to turn that down is because of what?
False negatives.
Yeah, we can't do cultures and we can't do antibiotic sensitivity testing. Okay. Renal tubular epithelial cells. These are those cells that line the renal tube. If there's greater than 3 under the microscope, if we see greater than 3 per high power field, that suggests kidney injury or damage. And what is another type of artifact that can be found under the microscope as well? Oval fat bodies that are commonly seen in what syndrome? Nephrotic. CAS, because you know they love to talk about CAS in this program. The most common type, hyaline, and that's not necessarily mean it's pathologic, right? It can be non-pathologic, but if we see a whole bunch going on along with some other things going on with your patient, we may be detecting or maybe thinking some type of glomerular. Cellular CAS, I think I have 2 slides on here on cellular CAS, yeah. So just RBC, white blood cell, renal tubular CAS, granular CAS, fatty CAS, and broad CAS. I'm trying to remember. Yeah, any CAS that you see in a nephrotic syndrome, just make sure you have that memorized, because you will be tested on that. All right, and crystals again. So that crystal that is associated with kidney stones, what's that called? Struvite or? Calcium oxalate, correct. And that picture, that calcium oxalate picture looks, I really like it, okay? The UTIs, you also see what other type of crystal in a UTI? It's down on the bottom. Ammonium biurate, correct. Mucus, so mucus does not necessarily mean there's something going on, but if there's other things, white blood cells, bacteria, red blood cells, and we see a bunch of mucus, then we're probably thinking there's some type of irritation or inflammation present with your patients. And then sperm in the urine, seen after sexual activity, but what I want you all to get here is that that problem with the bladder sphincter, or what? Retrograde ejaculation, and that means what? Going backwards, yeah. There you go. I think that is it. All right. Okay, so let's move on to chemistry 1. So there's a lot of biochem on here. I'm not testing you on biochem. Y'all already went through that course, and I'm not a fan of biochem. I'm just being straight up. All right. Let's see this here.
Ma'am?
Yes.
Before we start,
Sure.
not a great way to ask this.
Yeah.
Is there what's the real reason why before MAPS they don't want you to do anything that could cause you to have semen in your urine?
Well, semen, if you do a dipstick, sometimes semen does cause an increase in protein, okay? And if urine does need to go to culture, sometimes there is that bacteria that's on semen as well. So it could cause some false positives. That's something I can think of at the moment. And I don't even remember, well, I guess that applies to you all. So you were told specifically by the PA at MEPS?
Oh, they're like, don't do it the night before.
Oh, okay.
Not all.
Oh. Yeah, y'all experienced that too, males in the room? Oh, okay. I didn't know. But I will take a note and find out specifically. That's the only thing I can think of on the top of my head why they would say that. Yeah. Well, see, now you found the clever question for me. Yeah, yeah. Wait, what? Okay. Let's move on to chemistry 1. Hopefully this works.
Quit. Huh? Quit. Forget this stuff. Wait till here.
All right, so chemistry 1. So here we go. We are going to talk a little bit about the BMP and CMP. We already talked about that in block 1. We're going to dive a little bit more into the CMP, but today we're going to be focusing more on renal panels, electrolyte panels, and acid-base panels. Okay. So this is a picture up there of some old laboratories back in the 1940s, and off to the left, that's what our labs look like now. It's very, very much automated at this point. So that back in the day, they were using like the flask and the Bunsen burners, and they were pipetting by mouth and stuff like that back then. Now we just put the specimen on the machine and press a button. So, yeah. Okay, so here are TLOs, action conditions and standards are all the same, every class. Here are ELOs, okay? And this comes from your reference, chapters 9 and 15. So here's our clinical scenario. So this is a long scenario, but some of those questions are presented like this on your test, okay? A 64-year-old male with a history of hypertension and diabetes presents with confusion, weakness, and deep, rapid breathing. Vitals reveal tachypnea and mild hypotension. Labs include a sodium of 132, potassium 5.6, bicarbonate 14, BUN 45, creatinine 2.1, and glucose 388. There's an anion gap of 22. The arterial blood glass reveals a pH of 7.25, a partial CO2 of 30, and a bicarbonate of negative 14. These findings suggest a high anion gap, metabolic acidosis with respiratory compensation, consistent with diabetic, ketoacidosis, and acute kidney injury. All right, so let's deep dive into those labs, right? So we talked about BMP and CMP, right? Like I said, we're going to be focused on renal and electrolyte and liver for this class. So here's our lovely BMP. I know y'all got this down because y'all did great on that last test. But we are going to break down those labs or those analytes a little bit more, okay? Okay, so this is a good important slide, all right? So glucose, right? This is the simple carbohydrate, produces energy, it's an energy source. If you see high levels of glucose, it could indicate hyperglycemia, and that's seen in what? Diabetes, right? Okay, total calcium. Oh, I'm sorry, and if you see low levels, hypoglycemia, you're thinking some type of insulin overuse. Total calcium, this is bone health and muscle function, that's what we're testing for. High levels are called hyperglycemia or hypoparathyroidism, and decreased levels, hypocalcemia or hypoparathyroidism. Okay. Here's the BUN. Okay. So you will see that BUN increase in 6 to 24 hours after an injury. Increased levels can indicate some type of kidney dysfunction. Your creatinine, that measures the skeletal muscle contraction. And anytime you see these increase in creatinine levels, think some type of muscle disorder. And decrease is usually very rare, but it could indicate some type of severe muscle loss. Okay, so here's another important slide, all right? So I just want you all, we're gonna talk about pre-renal azotemia and renal and post-renal azotemia, all right? And so when we talk about azotemia or pre-renal azotemia, this is a condition where the kidneys are unable to filter those waste products from the blood, and and this leads to elevated levels of urine and creatinine in the serum, okay? Renal and post-renal azotemia, this is where there is an elevated level of nitrous waste products in the blood due to an impaired kidney function. Okay. All right, so they were breaking down sodium and potassium. You all have seen these on the BMP, right? Nice slide. But I'm not going to ask you anything specifically about these two. All right, so just know that the sodium deals with neuromuscular functions, and potassium deals with the cardiac muscle contractions. And so this is pretty much just showing how sodium and potassium moves within the body. I think you probably, I don't know if this slide is from biochem, but it looks too much like biochem. All right, so basic metabolic panel. Chloride, right? O2 and CO2 exchange in the red blood cells, okay? Increased levels of chloride, hyperchloremia, which is deal with dehydration and kidney problems. So there's gonna be a lot of questions on tests about dehydration and kidney problems, okay? Total carbon dioxide, this is primarily transported as bicarbonate in the red blood cells. And this is that bicarbonate buffers that acid-base balance, or that pH, right? So you see increased levels of total carbon dioxide, this thing, metabolic alkalosis, or secondary to respiratory acidosis. And then decreased levels metabolic acidosis and respiratory alkalosis. So we have a slide that's gonna break all that and has a mnemonic and everything like that. But this is an important slide, okay? And then, so the electrolyte panel is just a condensed version. It takes some stuff from the BMP and CMP and adds that bicarbonate. So electrolyte is the sodium, potassium, chloride, and bicarbonate, right? And then some other important electrolytes include calcium, magnesium, and phosphate. All right, so anytime you have patients that have some type of muscle weakness, some type of brain fog, confusion, you want to kind of look to the electrolyte panel. All right, so sodium and water balance. The basic concept is that sodium is the main driver of blood osmolality. Low sodium is hyponatremia, and high sodium deals with that highlighted word on the bottom, dehydration, okay? All right, so you will see you're gonna see I'm gonna break down these chemistry panels. It's very chemistry panel heavy on this test, okay? So this is a good slide for you all. If you don't understand osmolality, please make sure you get this slide out, okay? So if you have a hyponatremia, you're thinking someone has hyponatremia, they're gonna show with a hyposmotic, right? Where you see water excess, that's the mechanism. In the urine osmolality, you'll see that low or diluted urine, and you'll see a high concentration of SiADH, right? High is hypersomatic, and then normal is isomotic, okay? Okay, so hypernatremia in the sodium, right? So plasma osmolality will be high in hypernatremia. You'll see that in what? Dehydration again, and sodium excess. This is also seen in diabetes insipidus, okay? So sodium, think hypernatremia, you think of dehydration, and also seen in diabetes. Electrolyte potassium, regulated by insulin and catecholamines. In the blood acidosis, the potassium moves to plasma as the hydrogen enters the cells. In blood alkalosis, the potassium enters the cells and the hydrogen moves to the plasma. So the definition of hypokalemia is low serum plasma potassium, all right? So you'll see this a lot in those that have poor caloric intake, and the most common cause is in renal, so that's hyperaldosteronism or hyperaldosteronism. Secondary hyperaldosteronism. I didn't mean cuss. I know. Hyperkalemia, high. Serum plasma potassium, right, is really high. This is very rare, and so because it's rare, I don't test you on it. All right, electrolyte chloride, right? So that chloride maintains that osmotic pressure and electrical neutrality by opposing sodium. Chloride moves passively with the sodium and varies inversely in concentration to bicarbonate. And we're going to break that down a little bit more on this next slide. Okay. So, I mean, this looks all great and all, but it's too much like biochemistry. So, what I need for you all to know is that in the blood, 90% of CO2 is in the form of bicarbonate. Okay, that's all I need you to know. Anion gap. So you will see anion gap on your chemistry panels. There's going to be 5 questions that's going to have this on there. Okay. Okay. So when you see an increased anion gap, right? Think ketoacidosis, which is that buildup of ketones, or lactic acidosis, which is that buildup of lactate. If there is a decreased anion gap, that's associated with metabolic alkalosis, hypoalbuminemia, low albumin, and multiple myeloma, okay? Calcium and phosphate will also be on your CMP and electrolyte panels. And just know that these are inversely related. So calcium is inversely related to phosphate concentration, phosphate inversely related to calcium concentration. Right. So low calcium, high phosphate, hypocalcemia. High calcium, low phosphate, hypercalcemia. Okay, and then the inverse, right? The reverse. So, and honestly, these kind of cross match, right? So hypocalcemia is going to be the same as hyperphosphatemia. So you can just kind of put that X there. Hypercalcemia going to look the same as hypophosphatemia. Okay. So all I want you all to focus on this slide is that high phosphate and that low calcium. You want to think of kidney failure. Okay. All right, here's the BMP, and this is how it looks when it's presented to you all when you get those lab results. So you see that one that says dehydration. I really like that a lot. I think I even copied it. Diabetes, see how that's presented? Diabetes insipidus, okay? And those metabolic alkalosis, metabolic acidosis, I'm going to use a lot of those same numbers, okay? Okay, CMP, we talked about that in block 1, right? Albumin, alkaline phosphatase, aspartase, bilirubin, ALT, TP. Right. Another important slide. Albumin comprises 60% of total proteins. An increased level you see in dehydration, there's that term again, and in decreased levels, severe liver disease. ALP, this is found in the liver and bones, is involved in cell metabolism and protein breakdown. Anytime you see like an increase of ALP, you want to think liver disease, bone disorders, bile duct obstruction, and decreased levels you'll see in pregnancy and zinc deficiency. ALT, this is crucial for energy production, and AST is important for energy metabolism. Right? So a lot of these ALT, AST, we're looking at liver conditions, anything dealing with the liver. All right? And this is also an important slide as well. Right? Bilirubin and total protein. Right? You have your total bilirubin is the sum of the conjugated direct and unconjugated indirect bilirubin. So increased bilirubin, you'll see that in jaundice and liver disease, and decreased levels. I did not touch on that. And then total protein measures the serum, albumin, and globulins. Okay. and seen in dehydration and inflammation. Decreased levels of protein you'll see in liver or kidney disease or malnutrition. All right, so we've seen this slide entirely too many times, but I just want y'all to just get this down about the unconjugated indirect bilirubin. That's that non-water soluble, and it binds to the albumin in the bloodstream. And then you have your conjugated direct bilirubin that is water soluble and is excreted into the bile after conjugation to the liver, where it then becomes waste. Right? So here's another CMP panel. Dehydration, remember I said, know that you had those dehydration numbers, right? BUN is increased, BN creatinine ratio is increased, anion gap is increased, and osmolality increased. You'll see that dehydration. Okay. So these are the organs. You have already had AMP, so we don't skip. Oh, actually, we do not need to skip. Know that the EPO, I think I've already touched on that, but produce erythropoietin EPO, okay, in the kidneys. And these are the classes of plasma proteins. Just know that normal total protein is always higher in the plasma, but remember I will provide you with those reference ranges, so you don't have to memorize that, okay? And then the normal albumin to globulin ratio, 0.8 to 2.0. All right, so the albumin to globulin ratio, clinical significance, deals with anytime you have a low AG ratio, that can be a sign of some type of malnutrition or chronic illness. And the disease detection is various medical conditions that we will talk about here on this slide. All right, so anytime you see a low AG ratio, liver disease, malnutrition, kidney disease, okay? High AG ratio, dehydration, excessive fluid loss. Okay, important slide. All right, here's another one. Talking about albumin versus pre-albumin. And pre-albumin is that transthyretin. This transports the thyroid hormone, thyroxine, and the retinol building protein, RBP. It is bound to the retinol of vitamin A in the blood and the CSF. So if it's highlighted, it's probably important, right? So that nutritional marker as a late indicator of malnutrition and levels to decline slowly in albumin, and then in pre-albumin, early/sensitive and rapid indicator of nutritional status. All right. So GFR and clearance. So the GFR measures the rate at which the blood filters through the glomeruli. All right. The clearance actually reflects kidney efficiency in removing substance from the blood, and it indicates nephrotic functions. All right, so the measurements that we use in the lab for the GFR includes the creatinine clearance, the inulin clearance or exogenous, and the cystatin C. Okay, and the whole concept of the clearance is that we're just measuring the efficiency of the kidney. Okay. There's another slide. Yeah. All right, so here's that slide that breaks down those three tests: the creatinine clearance test, inulin clearance test, and cystatin C test. You will see these. Okay. I will have a panel that will have these markers on there. All right. So creatinine clearance test. This is creatinine is freely filtered, minimally reabsorbed, and secreted by the kidneys, and this is widely available in simple calculations. So this is the one you're going to see the most as clinicians is the creatinine clearance test. The inulin clearance and statin is available, but for the sake of you all, creatinine clearance test is what you'll see. The rest of these are kind of like a little more expensive, and not all labs have the test available. Okay, so inulin clearance test does the same thing, but it is the actual gold standard, but there's a lot of reference labs that run it, and not necessarily in clinical, like in a clinical lab. And then you have the cystatin C that requires only a blood sample and detects early kidney detection. Okay. But creatinine clearance test is what I want you all to get, and before I move on, let me make sure, I'm not lying to y'all. Okay, yeah. Creatinine clearance test. All right, so interpreting the GFR, these are the GFR interpretations. If you see normal, we know that they're healthy. If it's mildly decreased, 60 to 89, think stage 2 chronic kidney disease. Stage 3, moderately decreased, chronic kidney disease. 15 to 29, severely decreased, stage 4 chronic disease. And then less than 15, we're at kidney failure. So end-stage renal disease at that point. All right. This is a nice slide. It's just a nice slide, so we skip it. All right, clinical significance of NPN. You have ammonia and uric acid. So ammonia, we see high levels of ammonia, think kidney disease and liver dysfunction. Uric acid, high levels include kidney disease, gout, and decrease is rare, but seen in Wilson disease or Fanconi syndrome. All right, so this is another important slide, nephrotic versus nephritic syndromes. Okay? Make sure that you memorize this one. Okay? She'll be tested a couple times on this. So nephrotic is characterized by the disruption in the glomerular filtration barrier. This leads to increased permeability. Okay? Primary features, clinical features, you'll have those edema, tiredness, foamy urine, and the protein will be really high in these people with nephrotic syndrome, all right? Decreased albumin, high cholesterol, high triglycerides, waxy cast, and oval fat bodies in the urine, okay? So when I present this to you, I'm gonna have all these primary features in that clinical description on the test, all right? Nephrotic syndrome. This is characterized by inflammation of the glomeruli, all right? So same edema, hypertension, decreased urine output, but there's gonna be blood in the urine. You may see RBC cast and elevated BUN and creatinine, okay? All right, classification of kidney failure, acute versus chronic. Now, I won't necessarily test you on this in here, but you will need to know this moving on into your junior and senior semesters, okay? We will talk a little bit more about kidney functions, kidney failures, and things like that. All right, so acute kidney failure, think dehydration, infection, and chronic high blood pressure and diabetes. All right, and that's all I'm gonna say here. They're gonna get more. They'll hit you more later on as you move on in the program. Yeah, remember I said this is biochemistry and I don't like it, so. All right, acid-base balance and blood gases. So a normal pH balance is maintained by the 3 mechanisms. You have the buffering system, the lungs, and the kidneys, right? So the buffering system is that carbonic acid bicarbonate buffer system. You have the lungs that's dealing with that respiratory regulation, and then the kidneys that's dealing with that metabolic regulation. All right, so here are the normal arterial blood gas values. So remember, I'm gonna provide you with those reference ranges, but know what they are, right? So we already know pH. That PaCO2 is that partial pressure of CO2 in the arterial blood. Then we have the partial pressure of O2. SaO2 is the oxygen saturation. Then you have your serum bicarbonate, and then you have the percentage of metho-G and percentage of this carboxide, which I will not test you on that. So pH, the PaCO2, PaO2, SaO2, and bicarbonate, right? Those two on the bottom, you will not be tested on in this program. Later on, I can't help you out, but here, I'm not gonna do that to y'all. All right, so pH scale and arterial blood gas, ABGs. Okay, this is just a visual representation of what was on that first slide. If you like pretty colors and graphs, this is just another way to look at it. Okay, so off to the left, you have your acidic. In the middle with that greenish, calming, that's normal. And then when you start moving to that blue to purple, you think alkaline. For the pH, parts of CO2, and the bicarbonate. All right, so here's that mnemonic that I was saying. So this is a very important slide, so start, highlight it, whatever you gotta do, and make sure that you have this memorized, okay? So the mnemonic Rome, this is how we learn acid bases and imbalances, okay? So that RO is supposed to indicate your respiratory side, right? So increased pH, decreased CO2, think respiratory alkalosis. That O that's in blue, opposite, is gonna be the opposite of the R, right? So pH is decreased and the CO2 is increased, respiratory acidosis. And then you have the two on the bottom that are in red, that represents that metabolic side. So M for metabolic, increased pH, increased bicarbonate, think metabolic alkalosis, and E equal, which is gonna be decreased pH and bicarbonate, think metabolic acidosis. All right, so on top of the acid-base imbalances, we also have to think about compensation, okay? So when a patient is fully compensated, their pH is normal. If they're partially compensated, all three values will be abnormal. And an uncompensated patient will have their partial CO2 or bicarbonate is normal, but the others will be abnormal. And I think I have a scenario here. So that is just pretty much the same thing, right, but broken down a little bit more. Another slide to highlight, star, put a money sign, put some wings, whatever you need to do, okay? Make sure you have this down. Acid-base balance and blood gases, right? So low pH, acidemia, if the PO, CO2 is elevated, the primary process is respiratory acidosis. If the bicarbonate is low, think metabolic acidosis. With a patient with a high pH, alkalemia, POCT is low, this is respiratory alkalosis, and bicarbonate is high. The primary process is metabolic alkalosis. Okay, so if you have a female, right, she's vomiting for 3 days, she's taking excessive antacids, and she's showing some dehydration, right? Her labs show a normal pH, the bicarbonate is elevated. What are you thinking? Metabolic alkalosis, is she, there you go, see, y'all got this. Y'all got it. All right, so there you go, the money slide, so it's pretty much kind of the same thing we're already talking about. Okay. So I could use this in any type of scenario, and I know y'all will get the right answer. Any questions on this stuff so far? Because you know I'll be flying through slides, so I want to make sure y'all good. And so this is just a tic-tac-toe. This is just another visual representation of what we already talked about. If you need to see it a little differently, it's presented here differently. That's all this is saying. Okay, so here's a check on learning. A 44-year-old male with COPD presents with worsening and shortness of breath, fever, productive cough, tachycardia, and a bounding pulse, difficulty speaking, and cackles and wheezes in the lower lobes. Based on the labs, what is the acid-base disorder? So decreased pH, increased partial CO2, increased bicarbonate, and normal partial CO2. What do y'all think? Okay, so that pH is normal. Okay, acidosis, alkalosis, and respiratory acidosis partially compensated. Okay, so that's how just how you see in the scenario, that's how it's going to be presented to you all on the test. All right. Oh, we're still okay. Arrows are still going. Okay. All right. ELOs. All right. So we talked about BMP, CMP. We touched a little bit on the electrolyte panel. All right. I told y'all you need to know about the Anion gap, know those acid-base imbalances, all right? Know your renal functions and all of the clinical conditions that are associated with that. And y'all gonna rock this test. okay? All right, so I was told that I was supposed to knock out 2 of them today, okay? So y'all let me know if y'all need a break or we just need to push on through. You let me know. Oh, I hear a energy drink. Okay, that means push on through to me. All right, so.
Ma'am, just a quick
Yes,
question. So for these acid gas problems, you're gonna give us the normal range values on the test?
I will provide you with all the reference ranges. That is correct. Yeah. Yeah. Imagine if I had y'all remember, that's like way too much. Luckily, this slide here, or this one is only 31 slides. Alright, get some energy drinks out, stand up, walk, whatever you gotta do. This is painful for me too. Alright, lecture 4, clinical chemistry 2. Now we're gonna move a little bit more into diabetes, cardiac, and hepatic functions, okay? 31 slides, we can do it. Alright, so here are your TLOs, same, and ELOs, hepatic functions, diabetic management, cardiovascular disease, right? Our references come from chapters 17, 19, and 22. And here is our clinical introduction scenario. A 58-year-old male presents with chest pain, fatigue, and abdominal fullness. He has a history of type 2 diabetes and alcohol use. The lab showed elevated troponin, an AST-ALT ratio of 2:1, elevated GGT, and fasting glucose of 240 milligrams per deciliter. Further testing shows prolonged PTINR and a high BNP. These findings suggest acute coronary syndrome in a patient with underlying alcoholic liver disease and poorly controlled diabetes. So here's our panels again. The ones we're highlighting is the liver function and the hepatic function panel. Okay, so anytime we're thinking glucose, right, this is an important slide, right? You have your whole blood glucose, which is usually what you see when you get those finger pricks, like if you, for those that have to do with diabetic management, right? That's that point of care that you all can possibly provide at the bedside. And then you have the continuous glucose monitoring, and those are those indicators on the back of the arm or the thigh, right? And so those use interstitial glucose, and that's just that fluid that's just around the cells. So just know that glucose, continuous glucose monitoring, you do not need to do the fingerprints, that's already on the person's body. And you know, the GCM has a sensor that's inserted under the skin, either the back of the arm, stomach, or the buttocks. Testing interstitial fluid, right? Diabetes mellitus. All right, so this will be, you can see this again, okay? Type 1 is insulin dependent, all right? The mechanism is autoimmune destruction of the pancreatic B cells, prevents insulin production. Type 2 is non-insulin dependent, it's insulin resistant, and there's a B cell dysfunction as well for type 2. And then we have gestational diabetes, which you'll see within pregnant women, okay? All right, so if you have a patient who has polyuria, polydyspnea, intentional weight loss, and the result shows hyperglycemia, what is the most likely mechanism for his condition? So we have a patient presents with polyuria, polydyspnea, and unintentional weight loss. The lab results show a hyperglycemia. What is the most likely mechanism for his condition? Okay. Okay. The correct answer is autoimmune B cell destruction. Okay. And this is a 12-year-old, I'm sorry, I didn't mention it. It's a 12-year-old child.
There you go.
Sorry,
Ah.
hey. No, I know, sorry, I'm just tired. Yeah, it's a 12-year-olds, type 1. Sorry, y'all. Okay, let's move on. Lab tests to diagnose diabetes, hemoglobin A1Cs, fasting plasma glucose, and oral glucose tolerance tests. Right? This is from the American Diabetes Association. All right, so here we go. It's a breakdown of those lab tests that manage diabetes. You'll see hemoglobin A1C, we use that a lot, right? That's that main test we use for our diabetic patients, right? This measures that 2 to 3 month average blood glucose. Uses for diagnosing, monitoring, and treating those glycemic targets, and is unaffected by daily fluctuations. Then you have your fasting blood glucose, right? That usually consists of an overnight fast. We usually tell, or you all usually tell your patients to fast 8 to 12 hours before taking this test. They can take a private medication and don't need anything else before this test. And this also assesses the glycemic control. Then you have your oral glucose tolerance test. You see this a lot in gestational diabetes mellitus. And that's where you have the pregnant women drink that really thick drink. They tell you it tastes like Fanta, but it doesn't. It's really gross. They lied to me, but it's okay. Random plasma glucose. This measures the blood glucose at any time regardless of fasting. And then you have your urine microalbumin. This detects early signs of diabetic nephropathy. Okay. The hemoglobin A1C is our main one that I want you all to focus on. All right, so here are some other panels that you will use for any of your patients that you have diabetes. So you have your lipid panels. All right, so you would measure the cholesterol, LDL, HDL, and triglycerides. So do you all remember what LDL is? All right, HDL, okay, and triglycerides? Sure. Good enough. Serum creatinine measures the serum and plasma creatinine, weights of muscles and metabolism. Liver function test, you have ALT, AST, ALP, and bilirubin. And then your thyroid functions test, we will get that on Friday. We'll talk more about that. Okay? TSH3, T4, and T3. All right, so cardiac markers for AMIs, or acute myocardial infarctions. Troponin is your gold standard, so make sure you know that. Troponin is the gold standard for an acute myocardial infarction, okay? You want to, you know you have a patient that's had an AMI, you want to run this test within 1 to 12 hours because it peaks at 24 to 48 hours and returns to the baseline in 5 to 14 days. Okay. Then you have the creatinine kinase, or CKMB, all right? This is an alternative or secondary marker for AMI diagnosis, but a lot of times we'll see both troponin and CKMB. Then you have myoglobin. The role of myoglobin is to store and diffusion within the heart and skeletal muscle. And the significance is the early marker of muscle damage, but it's less specific for AMIs than the troponin. And then your BNP, your B-type natriuretic peptide. All right, this is that hormone that protects the heart from stress. All right, so elevated levels of HF or ventricular dysfunction, but they are not specific to AMI. And this is that key marker for heart failure. So that is very important. BNP is that key marker for heart failure. Okay, so here's just a breakdown of those cardiac markers, that troponin, CKMB, myoglobin, and BNP. And you see how AMI and heart failure are there? Yeah, so know that. Know that one. Heart failure. All right, inflammatory markers associated, we're about halfway through, y'all. Inflammatory markers associated with elevating cardiovascular disease. C-reactive protein, this is produced by the liver. Within a few hours after the start of an infection or inflammation, this helps assess the risk of cardiovascular disease and obesity. Then you have your high sensitivity CRP. This is more sensitive than CRP for cardiovascular risk. and it's, indicates cardiovascular. But CRP is what you're gonna see more than the high sensitive CRP. NPO, this produces those PMNs. Do y'all remember what PMN stood for? Neutrophils and macrophages, all right? This increases plaque instability and predicts the future of cardiovascular events, right? The next test is this SCD40L, soluble cluster of differentiation 40 ligand, all right? So this is used during a myocardial infarction risk. And then the TNF, or this tumor necrosis factor alpha, increase in non-fatal myocardial infarctions. Okay? And this can be produced in large quantities. So this is also an important slide. Okay? So know the NPO, the SD40L, and that tumor necrosis factor alpha. All right? I'm not going to spell it out, so just know the actual symbol itself or the abbreviation. Okay, so here is an hepatic function panel. This is what it looks like, and this is how we present it to you on the test as well. Albumin, total protein, bilirubin, LDH, GGT, ALT, AST, ALP, globulin, and AG ratio. All right, and so this is just going to be break down all those tests. All right, albumin, the most abundant protein, is synthesized by the liver. If you see an increase in albumin, what are you all thinking? Okay. And decreased albumin, seen in liver diseases, cirrhosis, things like that. Yeah. Total protein, low levels can suggest impaired liver function or malnutrition. Then we have your total bilirubin. You have fractions tested. I am not gonna put that on there. Straight up. I'm gonna test you on the total bilirubin. Okay, so know what total bilirubin is. Fractions tested on conjugated indirect bilirubin and then conjugated direct bilirubin. Just know total bilirubin. All right, here's that slide again. Next. All right, so I think we've seen this slide before. Which one of these jaundices has the tan colored feces? There you go. That's what you need to know. All right, evaluating the liver function. So here are those liver function tests. You have LDH, that lactate dehydrogenase. When it's elevated, it suggests tissue damage but lacks specificity for liver disease. Then you have GGT, all right? This is increased in cirrhosis, all right? And then fourfold or fivefold increase seen in chronic hepatitis, right? So I could possibly ask you 2 questions off this slide, right? This one as well. ALT and AST. ALT is most ongoing in liver disease, and AST, if it's usually exceeds that of ALT, if it's a 2-to-1, then you're thinking alcoholic hepatitis, cirrhosis, or heart failure. Okay. And this slide as well. All right. Couple of questions. So ALP, this is that enzyme found in the liver and the bone. It's important in bone mineralization and metabolism. Okay. You see elevated levels in the blood can be used as a marker for liver and bone diseases, and it's high concentration in those tissues. Okay. So ALP is elevated in bile duct destruction and in bone diseases. And then PT and INR, do y'all remember that from hemostasis lecture? Kinda, sorta. What do y'all remember about it?
Warfarin.
Yeah, warfarin in your communications, correct. Yeah. There you go, yeah, there you go. Measures the blood clotting ability. That prolonged PT-INR reflects an impaired liver function and reduced synthesis of clotting factors, okay? And so that will be associated with your liver panels. We almost there, we almost there. All right, here's our summary of all the stuff that I was blabbing about. But it's important that you know this, all right? So increased ALT and AST, liver injury, hepatitis or cirrhosis. Increased ALP and GGT, biliary obstruction, and then decreased albumin and total protein, impaired liver synthesis. Right, and those are gonna be the most common ones that you all will see as clinicians. I'm not gonna hit you with no esoteric, rare stuff that nobody's seen in 50 years, like I don't believe in that. Like I'm gonna hit you with stuff that you're actually gonna see and actually run on your patients, okay? So here's a liver function panel. Okay, so remember I was telling y'all, know what that hemolysis looks like, cirrhosis looks like. This is what it's gonna present. This is how it's gonna present on a liver panel. Diabetes and dehydration, right? Dehydration, diabetes, cirrhosis, hemolysis. Know those. All right, now we're moving on to the pancreas. What's the role of the pancreas, y'all? Sounds great. All I heard was, but that's okay. I know it was right. All right, so in acute pancreatitis, amylase rises within 5 to 8 hours of symptom onset. It peaks at 24 hours and returns to normal in 3 to 5 days, right? This is that enzyme that's produced by the salivary glands, and it breaks down those complex carbohydrates into simple sugars. You have lipase, also produced by the pancreas in the small intestine. The lipase concentration in the pancreas are 9,000-fold greater than any other tissue. And that is very important, okay? So make sure you highlight that, right? And it's more specific to pancreatic inflammation than amylase. Trypsin, this is a pancreas-specific enzyme. An elevated trypsin suggests pancreatic inflammation or injury. So here's that term again, pancreatic inflammation or injury. It's better than amylase and lipase for assessing the severity of pancreatitis. Okay, so what test out of the amylase and lipase was more specific? Do you remember?
Lipase.
Okay, there we go. Good. It's my favorite slide, the last yellow slide. So ELOs, we already talked about diabetes, cardiac and hepatic functions. We talked about diabetic management, cardiovascular disease, pancreatic functions, and all the common conditions. So remember, I want y'all to know diabetes, I want y'all to know hepatitis, I want y'all to know dehydration, myocardial infarction. So if you got that down, you're gonna ace the test, okay? That's it. That's all I got for y'all. I will see you all. I get the slow clap today. Okay, that's fine. I will see you all on Friday. We'll do our last block, okay? Hey,